Hello and welcome to ClinMed Compass. I am Dr. Kelvin, and in today's session we will be taking a look at urinary tract infection or UTIs. This is an essential topic in internal medicine and in clinical practice. As a medical student, you will frequently encounter UTIs during clinical rotations. Recognizing symptoms early, interpreting lab findings accurately, and selecting appropriate treatment are key skills every doctor must master. In this session, we cover the classification, causes, clinical features, diagnosis, and management of UTIs. We will also touch on special populations and preventive strategies. By the end of this lecture, you should feel more confident managing UTIs in your practice and your exams. So let's get started. What exactly is a UTI? It is an infection of any part of the urinary tract, from the urethra, the bladder, ureters, and the kidneys. It's usually diagnosed when there is an evidence of a bacterial growth in the urine along with symptoms and signs, mostly caused by bacterial organisms. However, rarely, viruses and fungi may be the culprits. It ranges from a mild disease to a life-threatening disease state. To understand UTIs, we must look at the brief anatomy and physiology of the urinary tract. The urinary tract includes the kidneys, the ureters, the bladder, and the urethra. The kidneys filter blood, produce urine, and regulate fluid and electrolyte balance. The ureters carry urine to the bladder through peristalsis. The bladder stores urine until voiding, and the urethra expels it from the body. Now let's highlight a few physiological mechanisms that help protect the urinary tract from infection. One is the urine flow. A continuous flow of urine mechanically flushes out bacteria from the urinary tract. Second is the urine pH and osmolality. Urine is often acidic and hyperosmolar, creating an environment that inhibits bacterial growth. Third is the uroepithelial defense. The uroepithelium has antimicrobial peptides and glycosaminoglycans that resist bacterial adherence. Next is the immune defenses. Local immune responses help detect and eliminate pathogens quickly. Another important point is the anatomical differences between genders. In females, the urethra is short, about 4 centimeters, and located close to the anus, making ascending infection more likely and fecal contamination also more likely. In males, the urethra is longer, at about 20 centimeters, and prostatic secretions have antibacterial properties. This provides some protection, which is why UTIs are less common in men, especially among the younger ones. Understanding these anatomical and physiological principles help us appreciate why certain populations are more vulnerable to UTIs. Now let us look at the epidemiology of UTIs. UTIs are among the most common bacterial infections encountered in clinical practice. They are second only to respiratory tract infections. They represent a significant cause of morbidity, healthcare visits, and antibiotic use globally. UTIs affect all age groups, but is especially common in women aged 16 to 35 years, infants, and the elderly. UTI affects approximately 150 million people yearly worldwide. UTIs account for 10 to 20% of all infections in primary care units and 30 to 40% of infections in the hospital setting. UTI occurs about 4 times more frequently in women than in males. About 10% of women experience a UTI yearly. Now let's look at the classification of UTIs. UTIs can be classified based on anatomy into lower UTI and upper UTI. The lower UTI is infection of the bladder and the urethra, as in cystitis, bladder infection, urethritis, urethral infection. Urethritis is often STI related, examples with chlamydia or gonorrhea. The upper UTI, the prototype is pyelonephritis. This is the infection of the kidney parenchyma and or the renal pelvis. Upper UTIs can progress to sepsis, especially if untreated. UTIs can also be classified based on complexity into uncomplicated and complicated UTIs. Uncomplicated UTIs occur in otherwise healthy individuals with normal urinary tract anatomy and function. UTI is said to be complicated when it occurs in patients with structural or functional urinary tract abnormality, such as diabetes, pregnancy, immunocompromised state, renal calculi, strictures, urogenic bladder, to mention but a few. UTI can also be classified based on recurrence. Recurrence UTI is the occurrence of 2 or more UTIs in 6 months or 3 UTIs in a year. Recurrence of UTI may occur in form of relapse or reinfection. What is relapse? Relapse is the occurrence of UTI with the same organism, often within 2 to 4 weeks of completing treatment. This could suggest inadequate treatment or the presence of an underlying abnormality. Reinfection, on the other hand, is the reoccurrence of UTI with a different organism, occurring after successful treatments. UTIs could also be classified based on setting. This is into community-acquired UTI. This is the UTI acquired outside the hospital setting, in our homes or within the community. It is common in women due to sexual activities and other hygienic factors. Nosocomial or hospital-acquired UTI. This is acquired greater than 48 hours after hospitalization, often associated with catheter use and resistant organisms. Now let's talk about the etiology and risk factors for UTI. Most common causative organisms are gram-negative. For example, Escherichia coli, Klebsiella pneumoniae, Proteus mirabilis, Pseudomonas aeruginosa. E. coli accounts for about 70 to 95% of uncomplicated UTI. They usually adhere to the uroepithelium using fimbriae. For Klebsiella pneumonia, they are associated with hospital-acquired infections as well as complicated UTIs. Proteus mirabilis is associated with the formation of struvite stone due to its production of urease. Pseudomonas aeruginosa is also seen in hospitalized or immunocompromised patients. Gram-positive organisms involved in UTI include Enterococcus faecalis. This is frequently found in complicated UTIs, especially when structural abnormalities or catheters are involved. Staphylococcus saprophyticus, a common cause in young sexually active women. Rarely but important are some of the non-bacterial pathogens, which include Candida albicans, a fungal organism usually seen in immunocompromised patients or those with long-term catheters. Viruses like adenovirus and herpes simplex virus can cause urethritis, though rarely. Bacteria use several strategies to cause UTIs. These are the virulence factors. One is adhesine and fimbriae. These help them to stick to urinary lining, resisting the flushing action of urine. Biofilms protect them from antibiotics and immune system, especially in catheter users. They also release toxins like hemolysin, which damage the tissues, and cytotoxin, which inflame the bladder lining. Lastly, urease enzymes, especially from Proteus, make urine more alkaline, leading to stone formation. These factors make UTIs harder to clear and more likely to recur. We'll be talking about the risk factors for UTIs. Several factors increase the risk for urinary tract infection. One of them is female gender, which is the major risk factors. The females have shorter urethra, about 4 centimeters, and the proximity of the urethra to the anus increases contamination risk. Increased risks during sexual activity and pregnancy also predispose them to UTI. Estrogen deficiency in postmenopausal women results in increased vaginal pH and therefore loss of protective lactobacilli. 2 is pregnancy. Hormonal changes in pregnancy, like urethral dilatation and reduced bladder tone, and the mechanical compression by the uterus lead to urinary stasis. Age is also a risk factor for UTI. In young women, the high incidence of UTI is due to sexual activity and hormonal changes. In postmenopausal women, estrogen loss reduces the protective vaginal flora. In the elderly, urinary retention from BPH and catheter use increase their risk of UTI. In neonate infants and children, anomalies like vesicoureteral reflux and congenital anomalies predispose to UTIs. The next risk factor is sexual activity. Frequent intercourse increases the risk of UTIs in young women, what we know as honeymoon cystitis. Irritants like spermicide, harsh soap, bubble baits, or scented products can also increase the risk of UTI. Immunosuppressed states like HIV, cancer, the use of steroid, or any other immunosuppressive therapy also contribute. Diabetes mellitus encourages bacterial growth due to sugar in the urine and weak immunity. Structural issues such as stones, neurogenic bladder, strictures also contribute to UTI. Catheters, especially when used on a long-term basis, are a major source of hospital-acquired UTIs. Finally, factors like poor hygiene, prior antibiotic use, history of previous UTI also raise the risks. Now we are going to look at the pathogenesis of UTI. First, let's talk about the host defense mechanism. The body has several natural defenses against urinary tract infection. First is the urine flow. This flushes out bacteria. Second is the pH and the osmolality of the urine. The acidic and concentrated nature of the urine also inhibits bacterial growth. Then the uroepithelium offers protection through tight junctions, antimicrobial peptides like phosphoroprotein, and glycosaminoglycans which prevent bacterial adhesions. The immune system is not left out. Neutrophils, macrophages, and immunoglobulin A quickly target invading microbes. Lastly, the normal vaginal flora, especially lactobacilli, helps maintain a protective environment. Together, these barriers they help to keep the urinary tract sterile. UTI arises when microorganisms overcome the host defenses. The development of UTI occurs in several key stages. One is colonization. Bacteria begin by colonizing the periurethral area, often from intestinal flora like E. coli. Next is ascension. These bacteria ascend through the urethra to the bladder, especially when defenses like urine flow are compromised. Using fimbriae and adhesins, the bacteria firmly attach to the bladder lining, resisting being flushed out. The next step is they evade the host defenses. They avoid immune clearance by forming biofilms and resisting antimicrobial peptide. Once they evade host defenses, they begin to multiply within the bladder and may spread to the upper part, including the kidneys. The host immune system reacts, leading to inflammation, pyuria, and cytokine release. Then we have the last one, which is tissue damage. Inflammation causes tissue damage, and you have subsequent clinical manifestation. This results in symptoms like dysuria, urgency, and fever. And if severe and there's ascension to the kidney, we will have pyelonephritis, and complications like urosepsis can also result. This cascade explains both the symptoms and complications seen in UTI. Now we'll talk about the clinical features of UTI. UTIs can present in different ways depending on the site of infection and the patient's age or condition. Lower UTI or cystitis typically causes dysuria, that is painful urination, frequency, urgency, suprapubic pain or discomfort, hematuria, and sometimes cloudy or foul-smelling urine. Fever is usually absent in lower UTIs. The upper UTI, which is pyelonephritis, is more severe. Patients may have high-grade fever with chills, flank or loin pain, which may be usually unilateral or could be bilateral, costovertebral angle tenderness, that's the renal angle tenderness, nausea and or vomiting, fatigue, and malaise. These patients often appear more ill and may need hospital admissions for intravenous antibiotics. Let's look at asymptomatic bacteriuria. This is the presence of significant bacterial growth in urine without symptoms. Significant bacterial growth is greater than 10 to the power 5 colony-forming units per ml of urine. So when we have significant bacterial growth without symptoms, that is asymptomatic bacteriuria. It is important to detect in pregnant women, people who are diabetics, and elderly patients, as it can progress to symptomatic infection. Usually, treatment is not indicated. However, we must treat in pregnancy, before urologic procedure, and in immunosuppressed patients. Then there is abacterial cystitis, also called urethral syndrome. This involves urinary symptoms without detectable infection. It is often a diagnosis of exclusion. Now for atypical presentation. In the elderly, confusion, falls, or lethargy may be the only signs. In pregnancy, symptoms may be typical or asymptomatic. Yet, untreated asymptomatic bacteriuria carries a 30% risk of pyelonephritis. In children, they often show non-specific signs like fever, vomiting, irritability, or failure to thrive. Always consider age and context when evaluating for urinary tract infections. Now let's talk about the diagnostic workup of UTI. Diagnosis of UTI starts with urinalysis. On dipstick testing, we look for leukocyte esterase, which suggests pyuria. Nitrite indicating nitrate-reducing bacteria like E. coli. Hematuria, which may be present, and an alkaline pH, which often points to Proteus infection. Microscopy confirms pyuria with more than 10 white cells per high power feed, presence of bacteria in urine, which is bacteriuria, and occasionally presence of white cell casts. Next is urine culture and sensitivity. This is the gold standard for diagnosis. It identifies causative organism and guides antibiotic therapy. A count of greater or equal to 10 to the power 5 colony-forming unit per ml of uropathogen in a clean catch midstream urine sample is significant. In symptomatic women, even 10 to the power 3 colony-forming unit per ml may be enough for diagnosis. Always obtain culture before starting antibiotic therapy. Blood cultures are done if sepsis is suspected. Additional tests like full blood counts, erythrocyte sedimentation rate, C-reactive protein help assess systemic inflammation. Imaging techniques such as renal ultrasound scan or CT urogram is reserved for complicated cases, recurrence, treatment failure, or suspected obstruction or abscess. Special tests may include cystoscopy for recurrent hematuria or suspected malignancy, and urodynamic studies for patients with voiding issues and frequent infections. Simple UTIs don't need imaging or invasive testing. Let's look at the differential diagnosis of UTI. When evaluating a patient with suspected UTI, it is important to consider other possible causes of dysuria and urinary symptoms. The non-infectious causes include interstitial cystitis. This is a chronic bladder condition with pelvic pain and urgency. Radiation cystitis. This is from previous pelvic radiotherapy. Nephrolithiasis or kidney stone can mimic infection symptoms. And bladder cancer, especially in older adults with hematuria. Sexually transmitted infections like gonorrhea or chlamydia can also present with urethral symptoms and must be ruled out. Finally, overactive bladder syndrome may cause frequency and urgency but without infection. A thorough history, exam, and appropriate test help distinguish these from true UTIs. Now let's look at the management of urinary tract infection. What is our goal of therapy? The main goals of UTI treatment are to 1. Relieve symptoms, eliminate infection, prevent complications, avoid resistance, and reduce recurrence. Look at the general measures of management. It is important to start empiric antibiotics based on common organisms and local resistance patterns. We should adjust antibiotics once culture results are out and address underlying risk factors such as remove catheters, control diabetes, and a whole lot of others, and encourage adequate hydration. Analgesic like paracetamol or NSAIDs can help with fever and with pain. For uncomplicated cystitis, first-line drugs include nitrofurantoin, fosfomycin, and trimethoprim sulfamethoxazole. Alternatives include cefalexin, amoxicillin clavulanate, ciprofloxacin. Treatment duration for lower UTI is between 3 to 7 days. In uncomplicated upper UTIs like pyelonephritis, in moderate cases, oral therapy will suffice. Options include ciprofloxacin or levofloxacin for about 7 to 14 days, trimethoprim sulfamethoxazole, and amoxicillin clavulanate combination for 10 to 14 days. However, in severe cases, patient needs to be admitted for intravenous antibiotics such as ceftriaxone, ciprofloxacin, piperacillin tazobactam, or carbapenems in resistant cases. We'll transition to oral antibiotics when patients become afebrile within 24 to 48 hours. Total treatment duration usually lasts for 10 to 14 days. For complicated UTI, treatment is usually tailored based on culture results. Initially start broad-spectrum antibiotics, then follow it by targeted therapy based on sensitivity results. Underlying conditions should be addressed, and for catheter-associated UTI, the catheter should be removed or changed, and antibiotics are also given based on targeted therapy. Treatment duration 7 to 14 days. For hospital-acquired complicated UTI, it is important to consider resistant organisms. For example, extended spectrum beta-lactamase risk. We can use ceftazidime avibactam combination, meropenem verbobactam combination. For candida infections, fluconazole for susceptible species and amphotericin B for resistant species. In special populations, pregnant women should be screened for asymptomatic bacteriuria at 12 to 16 weeks of gestation and treated early with safe antibiotics to prevent progression to pyelonephritis. Safe options include nitrofurantoin, avoid in late pregnancy, amoxicillin clavulanic acid, and cefalexin. For pediatrics patients, use weight-based antibiotic dosing and always investigate for structural abnormalities, especially in boys and infants. In the elderly, treat only if symptomatic. Avoid overtreatment of asymptomatic bacteriuria. Choose drugs with lower risks of side effects. Surgical intervention is rarely needed but may be necessary in obstructive uropathy, recurrent stones, chronic reflux, abscess drainage, and procedures may include lithotripsy, ureteral stenting, or surgical correction of anatomical abnormalities. Now let's look at the complications of UTI. Untreated or severe UTIs can lead to serious complications. Acute complications include urosepsis, a life-threatening systemic infection, emphysematous pyelonephritis, a gas-forming necrotizing infection of the kidneys, and renal or perinephric abscesses, which may require drainage. Chronic complications can develop over time, such as renal scarring, which damages the kidney tissues, chronic kidney disease from repeated or severe infections, chronic pyelonephritis, often with progressive renal insufficiency, hypertension due to scarring and loss of renal function, and in diabetics, renal papillary necrosis may occur. Early diagnosis and proper treatment are key to preventing these outcomes. Let's take a look at emphysematous pyelonephritis. Emphysematous pyelonephritis is a severe life-threatening kidney infection caused by gas-forming bacteria. It mainly affects diabetics, immunocompromised patients, or those with urinary obstruction. High blood sugar and poor tissue perfusion allow bacteria, especially E. coli, Klebsiella, and Proteus, to produce gas and destroy the kidney tissues. As stated earlier, positive organisms are E. coli, Klebsiella, and Proteus mirabilis. Patients may present with fever, flank pain, sepsis, or even altered mental status. Rarely, they may pass gas in the urine, a sign called pneumaturia. Diagnosis is confirmed with a CT scan, which shows gas in the kidney. Urine tests and cultures may help identify the pathogen. Management involves broad-spectrum intravenous antibiotic like carbapenem, piperacillin, tazobactam, and in severe cases, surgical drainage or nephrectomy may be advocated. Without treatment, it has a high mortality rate, but early diagnosis and aggressive care can save lives. Prevention of UTIs. Preventing UTI involves both lifestyle changes and medical strategies. Let's start with behavioral modifications. Encourage adequate hydration. Aim for 2 to 3 liters of water per day. Avoid holding urine for long periods, so patients should be advised to urinate regularly. To urinate after sexual intercourse, especially in women, and wiping from front to back after toileting, also in women. Avoid using irritating feminine products such as femicides or harsh soaps. For those with recurrent UTIs, antibiotic prophylaxis may help, either as daily low-dose treatment or post-intercourse dosing. Common options include nitrofurantoin, trimethoprim sulfamethoxazole, or cefalexin, but always weigh the benefits against the risks of resistance. We'll be looking at the non-antibiotic strategies that can be used as prevention. 1. Cranberry products. These may inhibit bacterial adhesion to bladder walls. However, there is limited evidence. The use of probiotics. These restore normal vaginal flora. Vaginal estrogen reduces UTI in post-menopausal women. The sugar D-mannose interferes with E. coli adhesion. Intravesical glycosaminoglycans for interstitial cystitis. Hygiene practices. Good hygiene is also key. Patient education is crucial. Teach early symptom recognition and prompt care. And at the public health level, promote antimicrobial stewardship and ensure follow-up of high-risk patients. Together, these strategies reduce infection risk and improve long-term outcomes. We will look at the emerging trends and research in UTI. We're going to consider the novel therapies. These include vaccines that target E. coli adhesins to prevent recurrence of UTI. They are still under development. Bacteriophages, these are viruses that selectively kill bacteria. They offer potential alternative to antibiotics. And monoclonal antibodies that neutralize bacterial virulence factors. We look at the technological advances. Technological innovations are also making an impact. Point-of-care diagnostics allow rapid bedside detection of pathogens and resistance. Artificial intelligence are now predicting UTI recurrence and guiding personalized care. Future directions. Looking ahead, personalized medicine and microbiome modulation hold great promise. By analyzing microbiome profiles and using prebiotics and probiotics, we can better prevent and tailor UTI treatment for individual patients. In summary, we have looked at UTI from definition to prevention. What are the key takeaways in this presentation? UTI are among the most common bacterial infections in clinical practice. E. coli remains the leading cause, though other organisms are often involved in complicated or hospital-acquired cases. Diagnosis is primarily clinical, with urinalysis and urine culture providing key support. Treatment should begin with empirical antibiotics guided by local resistance pattern. Prevention is essential through lifestyle changes, appropriate prophylaxis, and patients' education to reduce recurrence. And with advances in vaccines, diagnostics, and personalized care, the future of UTI management looks very promising. Thanks for watching. If you have any questions, drop them in the comments. We will be glad to respond. You can also reach us via the email in the description. If you found this lecture helpful, don't forget to like, share, and subscribe to ClinMed Compass for more concise and high-impact medical content. Let's keep learning, teaching, and improving patient care, one topic at a time. Thank you, and see you in the next video.